Welcome to Obstetrics and Gynecology Forum. I'm your regular host, Dr. Lani Yolabola. Last week, we were able to give us a background on the antepartum hemorrhage, which I explained means bleeding in late pregnancy. We told ourselves the implication and the importance of that topic. And we said last week that because of the importance of the topic and the volume, we are going to be presenting the topic in different parts. Last week we gave the overview, and I said the three important causes of antepartum hemorrhage vis-a-vis abruptio placentae, which is premature separation of the placenta, placenta previa, and rupture of uterus will be taken in different sections. Today, we shall be discussing abruptio placentae under this outline. Now, what is abruptio placenta? Why I said important? We said last week that for the most cases of bleeding that are severe enough to lead to complication are usually due to abruptio placentae and placenta previa. So we know that up to in up to 2 to 3% of women with massive bleeding, significant bleeding, placenta previa and abruptio placenta is implicated. And what is abruptio placenta? It means premature separation of placenta before delivery of the baby. And when we mean placenta separation, that means placenta that is sited where it is supposed to be sited, as against placenta previa, which I explained last week is located in the lower part of the uterus where the baby usually comes out of the uterus. But in abruptio placenta, the placenta is normally located, but bleeding is now coming from the placenta that is normally located because it has separated prematurely. Placenta normally separates after the delivery of the baby for the placenta to also be delivered. But once it separates before the delivery of the baby, we refer to it as placenta abruption. And usually it occurs from around the beginning of the third trimester, from after 26 weeks of pregnancy. That is why when this usually occurs. And it has been said that it can occur in up to 1 out of about 80 deliveries. That means 1 out of 80 women that had deliveries will have this complication. Now, the good thing is that it's not every case of placenta previa, that placenta abruption, that will be severe enough to cause major complications in the woman. And for those that are severe enough to lead to the death of the baby inside the womb, it may occur in 1 out of 500 or 1 out of 750 deliveries. That means it's rare. So, but importantly, is an important cause of complication in pregnancy. Now, talking about the severity of the symptoms, we have also known that in about 30% of cases of placenta separation, it may not be severe enough for us to even diagnose it. Some of them are actually diagnosed after the woman had delivered, and you now deliver the placenta and you notice clot of blood. That's like a congealed blood behind the placenta, indenting that surface of the placenta. So now, placenta previa, placenta abruptio, pardon, placenta abruptio can occur in under two major categories. It can occur and the blood will come out through the vagina, and we will see the quantity of blood coming out. We refer to that one as revealed abruptio placentae. And sometimes the separation may occur and the blood is still retained within the womb. We call that one concealed, and the concealed one will occur in about 20% of cases. That means 1 out of 5 cases will be concealed. What we mean in concealed is that this is the placenta. The bleeding has occurred just behind that right portion. The bleeding has occurred behind the placenta and is trapped within the uterus. It's not coming out. And for the revealed one, the bleeding, the placenta separation may occur around the margin of the placenta. If it occurs around the margin, and the blood can now trickle down and come out through the vagina. This one, the concealed one, may occur in about 80%, but Despite the fact that the blood is not coming out, is usually the most severe form, because the blood may be trapped in a very large volume to the extent that the whole placenta can be separated from the womb, and once the placenta is separated totally from the womb, it will cut short the blood supply to the baby. So the incidence of fetal death or death of babies in the womb is commoner among the conceived type. Now, sometimes, especially in the marginal separation of the placenta, the blood may not be revealed because this membrane, that sac that is covering the baby, may trap the blood and prevent the blood from coming out. Sometimes the blood can also trickle into the liquor, into the water in the womb, and also into the muscle of the uterus. So it can be mixed, that in a situation where some of the blood is trapped and some is coming out, is we refer to that one as mixed abruptio. Or sometimes it can be relatively revealed because parts of it is coming out and parts is going into the amniotic cavity. Now, what are the causes of abruptio placenta? We should be worried. Women should know why they may be predisposed to premature placenta separation. Now, the causes may not be readily determined, but there are some factors that we refer to as either predisposing factor or precipitating factors. Predisposing factors are factors that may occur in a woman that will make you have a higher likelihood of coming down with conditions. And precipitating factors are factors that, despite the fact that you're having that condition, if those factors don't occur, the disease may not manifest. Now, talking about predisposing factor in the causation of abruptio placenta, one important factor is the fact that if a woman has had placenta premature separation in previous pregnancy, the likelihood of having it in this present pregnancy is higher. So if a woman has had one episode, the likelihood will approach roughly 20%. In the second, that's 1 out of 5 chance of having it in the subsequent pregnancy. If a woman has had 2 episodes, the likelihood will go above that 1 in 5. That means if a woman has had it once, she's at risk of having it the second time. That is important in management, because a woman that's had it once should be monitored in subsequent pregnancies in a good facility. Now, the other important cause or predisposing factor is hypertensive disorders. Hypertensive disorders means when your blood pressure is high, whether you have been diagnosed as a known hypertensive, which we refer to as chronic hypertensive, or what we call hypertensive disorders in pregnancy, that's pregnancy-induced hypertension. A woman that was not ab initio pregnant, but the blood pressure starts going up in pregnancy, those ones are also associated with separation of the placenta. It has also been found that women that have multiple pregnancies, twins, triplets, also they also have higher predisposition. Women that have large volume of liquor, we call it hydrangeas. The water surrounding the baby in some pregnancy will be so large, larger than normal. Such women are also predisposed. Women that are predisposed to trauma can come in different forms. There's something we call version. Version means that if a baby is coming with the leg or with the buttock, attempts may be made to rotate, to turn the baby to the head to facilitate delivery. During such procedure, placenta can get separated. So direct trauma to the abdomen too can cause it. Direct heat accident, road traffic accident that has direct impact on the pregnant abdomen, or trauma from seatbelt accident, direct hits or impacts on the abdomen too can predispose to this condition. Another important factor is the issue of blood disorders, the blood vessel disorders. Any condition that will affect the blood vessel in the placenta in the woman can predispose to separation. Things like diabetes mellitus, conditions like cognitive disorders, connective tissue disorders, and some immunologic disorders that are actually, because there's something we call sick placenta syndrome. If the vessels are sick, they are not strong enough, they can be predisposed easily to rupture. So by and large, those conditions are very important. And smokers, Smokers too are predisposed. Cigarettes, especially people that take 10 or more sticks per day. Alcohol consumption, it's not good it's not good in pregnant women. A woman that takes up to 14 bottles per day or more per day are also predisposed to this. Women that have had so many deliveries, they have had 4 or 5 deliveries. The higher the number of deliveries, the higher the predisposition. The older the woman, the higher the predisposition to this condition. Women above 35 years of age are more predisposed to this condition. And what are the precipitating factors? Precipitating factors are factors that will now make the condition to manifest. For example, let's say for instance a woman that has trauma, direct trauma, with the background factors. That is why when the woman has trauma to the abdomen, no matter how minor it should be, especially when the placenta is located in the anterior part of the womb. Now, what of function that I have explained in trying to rotate the baby, crack hook, there is going, what do you call it? Sudden decompression. Maybe a woman is in labor carrying twins or triplets. When one of the twins has been delivered, the volume inside the pressure inside the uterus will be reduced. So the second baby is predisposed to be subjected to placenta separation because of the sudden reduction in the volume. But when a woman has that large volume of of water within the uterus, and once the membrane ruptures and the volume reduces, that sudden change in pressure can also make the placenta to separate. So what of women that have very short umbilical cord? The umbilical cord is the cord that is linking the placenta to the baby. If it's too short and the baby is coming down through the bowel canal, there can be a pull, a sudden pull on the cord, and such can separate the placenta. The other important factor is sudden change in pressure in the woman's system. For example, a woman that has shock, because of that shock, there is sudden reduction in the blood pressure, and which will be compensated for within the uterine vessels with increase in blood pressure. Women that have been exposed to what we call conduction anesthesia, some anesthesia that can reduce the blood volume. So those changes in pressure can also cause the placenta to separate. That's said about the causes. Then what about the mechanism? Like I explained, the primary factor is bleeding behind the placenta. Now, what are the mechanisms that can make a woman to bleed behind the placenta? We have talked about the predisposing and the precipitating factors, but like I said, it can be due to the local problem in the vessels of the uterus or the placenta. So there are any condition that makes this vessel to be fragile will make the woman to easily bleed behind the placenta. Conditions like hypertension, which can be chronic or pregnancy-induced hypertension, conditions like renal disease, conditions like diabetes mellitus, chronic renal disease, those conditions and connective tissue disorders like collagen disorders, those conditions may make the vessel to be liable to bleed. Now, the second condition, like I said, is the sudden change in pressure. Any condition that makes the pressure to change suddenly will also predispose the woman to bleeding. Then what about trauma? Direct trauma. If the placenta is located anteriorly and there is a direct hit on the uterus, it can make the woman to bleed. And what happens when the woman is bleeding? Now, I've said that the woman can continue to bleed. The bleeding will now separate. This bleeding will continue to separate the placenta, and once it's separating the placenta, some blood can separate the placenta totally, and once that occurs, blood is cut off from the baby. Now, blood can also seep into the amniotic fluid cavity. Blood can also come into the amniotic fluid, and that blood can mix with the amniotic fluid, and the amniotic fluid can also come into the maternal blood, which we call amniotic fluid embolism. We can go into the lungs and cause serious problem and death in the woman. The blood can also track into the muscles of the uterus. This blood can also track into the muscle of the uterus, and when blood has tracked into the muscle of the uterus, it will make the uterus look like dead meat. That part of the uterus will not be able to contract again. It will become dead. We call it uteroplacental apoplexy. Don't mind the big grammar. So it just means that that part of the muscle of the uterus is dead because of the extravasation of blood into that part of this. And another important thing is that if the bleeding is massive, the woman can go into shock. And when there is shock, the blood flow to other parts of the body will be reduced, to the brain, to the liver, to other organs of the body, especially in the kidney. If the blood that is getting to the kidney is reduced, it can lead to renal failure. That can lead to the kidney shutdown. Now, when a woman is bleeding and clot is forming, there are some chemicals or agents in the blood that we call clotting factors and fibrinogen that makes those factors that make blood to clot. Those factors can be used up, and the woman will not be able to, the blood will not be able to clot again. The woman will just be bleeding uncontrollably from the teeth, from the skin, from every part of the body. And those agents can also go to the lungs and cause lung failure, go to the heart and cause heart failure. And the massive bleeding, when the woman has lost so much blood, it can lead to death, it can lead to shock. So when you look at everything together, you see that this condition is really very, very important to be monitored. Then let's talk about presentation. What will happen? What will a woman see? What will, as a woman, when you are pregnant, what will you notice that will make you suspect that there's a problem? As a point of to note, any woman that has abdominal pain in pregnancy should go to the hospital. Don't assume it's minor pain. Like I said, in about 30% of cases, the separation may not cause any other problem. But how do you determine the ones that will lead to further problems? So when you notice any abdominal pain, because abdominal pain is the commonest cause, the commonest presentation in pregnancy. 8 out of 10 women with this condition will have abdominal pain. So when the abdominal pain will occur, usually when it occurs when the placenta is located anteriorly. Some people will present with back pain. That is when the placenta is located in the back. So it can be abdominal pain, it can be back pain. About 70%, like 7 out of 10, may have there is the form of contraction, bleeding. Sorry, bleeding. 80% bleeding. That may be the bleeding. Sorry, the commonest is bleeding. When you start noticing any form of bleeding in pregnancy, go to the hospital. 8 out of 10. Abdominal pain, like 7 out of 10. Abdominal pain, back pain can occur. About 7 out of 10 women will have that. Then symptoms that may look like labor pains, whether your pregnancies are term or not. Once you have features suggestive of contractions, labor-like pains, please don't assume it is labor. Go to the hospital, because in about 20% of cases, it may start like what we refer to as forced labor. You just have some contractions and contractions go down. It may be a sign that part of the placenta are separated. And for women that have trauma, it's easier to, you have road traffic accidents, domestic violence, fights, anything that causes direct impact on your pregnancy. Please go to the hospital to be examined. Then the other ones that may predisposition, hypertensive disorders, rupture of uterus. That is why we normally say once a woman is draining, please don't assume labor will soon start. Once you are draining in pregnancy, go to the hospital, because sudden reduction in the volume of the liquor may make the placenta to separate. So by and large, those are the common symptoms that you may. And when you get to the hospital, what will your doctors do? Doctors want to examine your general outlook, and first and foremost to look at the check for the condition of your baby, because in certain cases the baby will be in distress, or sometimes if the separation is large, the baby might be dead. So if you pick the baby at the point of distress, your baby can still be salvaged. So sometimes when you come, you do certain investigation, especially you pass a volume, but you have to know that to assess the level of the blood loss may be difficult, because like I said, some of the blood may be just trapped within the uterus. So the blood that is coming out will not be able to tell us how much blood you have lost, and the level of blood, what we call the parcel volume at that level, may not be reliable, because at the point when the bleeding has just started, what we call equilibration will not have occurred. So the PCV that may be getting may be the blood level that you had before the problem started. So that may not be reflective. So please, when you notice any of this, go to the hospital. The doctor may also want to do some other investigations to look at these things that are referred to as clotting profile and the clotting agents in the body. There's different tests that you can do. You can check for clotting. If the simplest that you can do is to do what we call bedside clotting time and clot assessment. So it will tell us that have you lost so much clotting product that you are predisposed to uncontrolled bleeding. They have quoted that PT, PTTK, and fibrinogen assay, fibrin degradation products, which are beyond the scope of this discussion. But there are some tests that they can to determine. Let me note here that ultrasound may not be too helpful in this condition because the bleeding behind the placenta may not be easily picked up by ultrasound. So the ultrasound may not be, and then when you have they have done the initial assessment, the woman has presented in the hospital, they have done the assessment, they have done the basic investigations, then the treatment. Now the treatment may come under different forms. Like I said, some patients have little or no symptoms, some with severe complications. When the woman comes in emergency, a woman that's bled so much in shock, maybe the fetus is dead and everything, or the separation is ongoing. Such women are managed as emergency. You want to quickly stabilize them, give them fluid to replace the to support the blood volume, quickly cross match about 4 units of blood and transfuse. And what we do is we set two lines. They may put light cannula in your two hands to quickly rush fluid and manage their body. But for patients that have separation of placenta that have been diagnosed, and the baby is still stable in the uterus, or the bleeding is not massive, or there is no ongoing bleeding, then we have examined the woman is stable, we have examined the baby is also stable. For such women, we can do what we call expectant management. What we mean by expectant management is that further examination of the baby is carried out, further examination of the woman is carried out, the uterus, to monitor that is there any ongoing bleeding, is the bleeding worsening or is stable. The such women are examined within the labour or delivery suite with all these tests. And if after 48 hours, which about 2 days, no further bleeding has occurred and the woman is stable, such women can now be categorized into two. Do we put them on bed? Usually it occurs in pregnancy that have not been to term. If the pregnancy is at term, why wait again? The woman will deliver. But if the baby is not matured enough, you see that the baby may have challenges living independently after delivery, then you can separate it into two. Now, is the woman stable enough to go home, or do you want to keep such women in the hospital? If they are stable, you send them home with further monitoring. If they are not stable, keep monitoring them on the bed until the baby is mature enough to be delivered. For vaginal deliveries, women that come in that are term in labour, and there is favourable chance of having vaginal delivery, the baby is not in distress, the woman is not in distress, can still be delivered through the vagina. Otherwise, some women too, they have come with a baby that is not viable and their condition is critical, it's not, and the labour is advanced, and you know that is either the baby is dead or the baby is not likely going to make it. Why put double jeopardy? Why doing surgery for a baby that may not survive? Such women too can be allowed to deliver through the vagina. The caveat here is that for a woman that is having massive bleeding or the clinical condition is not stable, such women will now move to the level of what we call cesarean section. That is abnormal delivery, abdominal delivery. For a woman that is bleeding profusely, whether the baby is dead or alive does not matter. For a woman that has ongoing bleeding in the uterus and the uterus is getting larger and larger, the clotting system is getting deranged, such women, you may not be able to wait for them to deliver on their own. To save the life of the woman especially, you may have to do cesarean section, deliver them through the abdomen. Now for such women, it's important to know that when you get to that condition, it's about life and death. So Like I said, once the clotting agents have been used up, the woman can bleed to death even during surgery. So for such women, they have to provide means of controlling that clotting derangement. So which we are going to talk about with things like fresh whole blood, the blood that just been collected from another individual, or some blood sort components that contains all those factors that we need. So that's said. Now, and let me say here that for some people that have severe uterine apoplexy or uterine death, they may need to do hysterectomy for them. So, in order to save the life of the woman, because most of the women that die because of bleeding are either because the diagnosis is delayed or the definitive management is delayed. As obstetricians, we prefer to sacrifice the uterus to save the life of the woman. So sometimes you may be cancelled for what we refer to as hysterectomy. Your uterus may have to go just to save your life. So you have that at the back of your mind. There is someone that is alive that can think of taking care of children. So what are the likely complications of this condition? Like I've said, clotting derangement, coagulopathy, amniotic fluid embolism, heart failure, can lead to heart failure, kidney failure. So, and the other thing is what we call lung failure too can occur. Embolism can those sometimes that I talked about can get into your lungs, destroy the lung, destroy the kidney, destroy the heart, and so on, and can lead to death. So for such conditions, the management of complication too is very intensive. It's not it may get to a state that your obstetrician will have to invite the physician, the emergency physicians to manage some and end up in intensive care units. So cases like this are not taken for granted. And conditions in the baby can lead to death of the baby, distress and serious disability. Even a baby can come out alive but with serious mental disabilities. So by and large, yeah, then what are the outcomes? It's very important that we talk about the outcome, because the outcome of this condition will depend on how early the diagnosis is made. So if you go to the hospital on time, the diagnosis is made on time, and management can be instituted on time, you have a higher likelihood of survival, and the baby also has a higher likelihood of survival. The outcome may be poor in women that have come in early labor. They may need to, or they are not in labor, women that don't have so many babies and they end up losing their uterus. We've seen cases like that. But for women that come in advanced labor, the fetus is still alive, they have better outlook. So by and large, we've been able to explain what premature placenta separation is, and we have tried to justify why it's an important topic. Please let me sound it again, that pregnancy should be made safe, not only by the doctors but by the pregnant women. Don't underrate any condition in pregnancy. Don't just think it's normal. Whenever you notice any of these major conditions in pregnancy, bleeding, pains, drainage of fluid through the vagina, please present to a good hospital. Your doctors will assess you. Let them be the one to determine whether your condition is serious or not. Thank you. I hope you enjoyed the discussion. Watch the video. If you have any comment or questions, don't hesitate to get back to us. God bless.